Much. Hope those videos were helpful. Can everybody hear me? Okay, good. Remember when you, if you come back on, that your mic will probably come on as unmuted. So just be aware of that. If I hear background noise, or if we hear background noise, we'll just let you guys know. So I left you with, first of all, were those videos helpful at all? Were they interesting? Do they give you sort of an overall with regard to some of the symptoms and things like that? I think all the links did work with regard to that. So hopefully those were helpful. Those may also come in helpful from a standpoint of the when we get to talking about pharmacology, when we start talking about the oral contraceptives and some of the drugs there, like I've told you guys before, what I tend to try to do is to use very similar slides. So it's not like you're being introduced to something totally new. And I try to use some of these videos, assuming, it's interesting. I was talking to a colleague of mine the other day, and we were talking about that we'd found great videos for using in class and stuff like that. And then it's like, for some reason, they get taken down and we have to go hunt. And sometimes the new videos are not anywhere near as helpful as the other videos. So, but I do find that some of these animations, a lot of times that the drug companies do, actually work pretty well because they spend a lot of money for using these and, at medical conferences and things like that. So we can take advantage of those. The downside of them is they are definitely presenting their side of the drugs. And so you have to be sort of balanced with that. So, so what I did was I left you guys with a, with the question that dealt with what would we see with regard to the different situations here. So as I said, that the what we're going to see here is that on all three of these we have a characterization of, let's see, we see that there's, sorry guys, we see that there is a characterization of low T in all three conditions, okay? So we know that all three are going to have low T. The question becomes, just because we have low T, and when I say low T, it's testosterone, then the question now becomes is, what do we see in primary, secondary, and tertiary with regard to the gonadotropins or the gonadotropin-releasing hormone? So in primary, we have low testosterone, but what we will find is, what would the gonadotropins, so FSH, LH, and what would FSH, LH releasing factor? Would those be elevated? Would they be decreased, or with normal? Okay. So typically we would either see these would be normal, or the other option would be they would be elevated. And the reason for elevation would be when the testosterone went down, then the body is going to pick up that we're at low testosterone. So the idea would be that we were going to try to stimulate more release of testosterone. So what we typically would see is that in primary, so that the testicles are not what is producing the testosterone. So there's something wrong there, but the other system would be trying to drive it. So we typically are going to see initially normal, and maybe normal to elevated, and more likely over a period elevated. And for Jason, basically it's the same feedback system. So just like we talked, if you go to the very first slide that we had on this slide bank, remember that feedback with the hypothalamus. So when the testosterone levels go down, what's going to happen is, typically for a little bit, we may have the levels around normal with gonadotropin or the gonad with LH or SH, or with the gonadotropin releasing factor. But then what happens is, basically it tries to stimulate it. So because there is no feedback to turn it off, we see those typically are elevated. Um, so that's when the damage or when the dysfunction is occurring in the testicles. All right, let's go to the secondary. So secondary, what happens is that the pituitary is dysfunctional. So what we find here is that something is wrong with the pituitary gland. And so we're not getting release of luteinizing hormone and probably not FSH. So those are down, and we have low testosterone. What's going to happen with gonadotropin releasing hormone? So for secondary, you would see testosterone is low because that's going to be low for all of them. You would see exactly, Jason, is that you would see that the pituitary dysfunction, so the LH is low and the FSH is low. So those are the gonadotropins, and then you would see probably an increase of the gonadotropin releasing hormones. So in this case, the hypothalamus seems to be functioning normally, and it's trying to drive the pituitary to release the gonadotropins, but the pituitary is a dysfunction. And since it's not functioning, it's not going to respond to the gonadotropin. And so what you're going to see is that would be a situation where that you would have low testosterone because you have very little. You're having nothing to stimulate the testes to release the testosterone. So in primary, what's going to happen is basically, let's just go through them again. So with primary, so all three of them, we're going to have low T, all right, low testosterone. The question is, where is the defect? Where's the dysfunction? So with primary, the dysfunction is actually with the testes. So basically, there is something wrong with the testes, so they cannot make or release testosterone. Okay, the other system are working. In fact, the other systems may actually be elevated because they're trying to drive. They're trying to get. They're sensing low testosterone, so they're trying to drive or to get more function there. Let's see if we can go back here. This may be a little easier to, yeah. All right. So with this, what happens is if the dysfunction is here, if the dysfunction is in the testes here, what this means is that you get low testosterone, and it then means that this would signal the anterior pituitary and the hypothalamus that we need to get more testosterone. So they're going to be releasing. So what we're going to see with primary is low T, typically elevated gonadotropins, the LH, FSH, and typically elevated GnRH. So the hypothalamus and the pituitary are trying to be active to increase testosterone production. So that's primary. With secondary, the action appears to be up here in the anterior pituitary there, okay? So what we see here is that we have low T, we have low anterior pituitary action, typically LH and FSH are going to be reduced. But what we see is the gonadotropin releasing hormone up in the hypothalamus is going to probably be elevated. So it's getting the feedback that there's low testosterone down here, and it's saying, okay, we need some more. So it stimulates this. This is releasing, but the problem is they're not getting release there. Okay, so that's the situation. Now, in tertiary, what's happening is the dysfunction is up in the hypothalamus. So what we find is there is low GnRH, there is low anterior pituitary because there's nothing to stimulate the anterior pituitary directly. Although we may see in a stage as the low testosterone may try to get the pituitary to release a little bit. So typically what we see is in primary, we have low testosterone, elevated LH and FSH, elevated GnRH. In secondary, we have low T, low gonadotropins, low LH and low FSH, and potentially elevated GnRH. And then in tertiary, we have low GnRH, which typically will tend to have low gonadotropins and low T. Okay? So just think about where it is happening there. So the point becomes when you get low testosterone, that stimulates the brains to saying we need to get more testosterone produced. And so the brain tries to send the signals down. But the problem is the signals are coming down, but the end organ, the testes, basically is not functioning. So it keeps trying to send the signal. It's like somebody, trying to get you to do something, and they're yelling, and you're not doing it. So they're standing back here yelling, you need to do this, you need to do this, but you're either not hearing them or just not doing it. Then the other system is where that something's not getting done and somebody is not telling the person to get it done. And then so it's like your boss tells the boss tells the secretary to tell you to do something. Okay. So if it's primary, you just ain't doing it. Okay. If it's secondary, the boss is telling the secretary, but she's not telling you, so it's not getting done. And then if it's tertiary, the boss ain't telling you, so the secretary doesn't tell you, so you don't do it. So how was that for an analogy? So, all right. That was just off the top of my head. I must have been what happened is at lunch, I took my, the little dog Barney was driving everybody crazy in the house here because he was spinning around. And so I took him up to throw some stuff up away at the recycling. And so I thought usually he calms down for a good ride. Well, no, that didn't work. It was just like I took him outside and he was like, wow, I get all this stimulation. So he was worse off when I brought him back in. So I put him in the room with my wife over there. So he's terrorizing all the dogs but Big Al. So, all right, let's move back. So just make sure you got that sort of down. And we're going to get back to the slide here. So this is what we had here. All right, so now let's talk about this low T. First of all, do you guys remember the ad about low T, the testosterone supplements that was on maybe 5 or 6 years ago? Does anybody remember those? Okay. Geraldine does. So, well, some of you do, some of you may not. All right. So for those that you don't remember, so what happened is there was a big push that the drug companies started that started really pushing for this condition called low T. All right. And low T, there is a natural age-related decrease in testosterone. Okay. So as you start getting older, the testosterone levels go down. And for years, people have thought, well, the reason we, are tired and our sex drive goes down and all of these other things are occurring is because we see our testosterone goes down. And so several years ago, people started trying to, in fact, they first started trying to promote DHEA, which was a over-the-counter supplement, which was a androgen or a natural androgen. And the idea is that the decrease in your virility and everything occurred because your testosterone or androgen levels went down. Okay. So the drug companies came in and they said, basically, they target really men 50 and older. So the idea is that they, I think one of the ads typically showed a guy that is in his 50s and then his shadow would be behind him, or he would be walking around with his head hanging down and so forth. And it says the shadow would be, the ad would say something like, what happened to all that energy and everything that you used to have? And his shadow would be sort of dancing and all this other stuff in the background. And it says, you may be suffering from low T. Okay. And so as a result, we saw several testosterone products that basically hit the market. Many of these, they were administered underneath the arm. You could also, some were given by injection, but the ones that were really pushed were typically you put them underneath your arm and like a deodorant, and you put it on once a day or whatever. So basically, the fact is that if you take an older man, someone in their 50s or older, their testosterone levels are going to be lower than, say, somebody in their late teens or 20s or 30s. So the idea was that obviously a lot of the things that we fatigue and tiredness and so forth that we experience when you're older must be due to testosterone. So the drug companies really promoted it. And they would say, don't be afraid to ask your doctor. In fact, the shadow, sometimes one of the ads, the shadow would be talking to the guy saying, the guy apparently was going to see his doctor, and the shadow says, are you going to talk about it? And then they would come back and the drug companies would say, hey, it's just a number. So it was sort of like not wanting men to feel like there was anything wrong with them, and it was okay to that being otherwise normal. It was okay for you to take this because you're really just treating a number. I never liked that because it's almost like we're treating a lab value. So the idea was that if you're over 50, basically that needed to be that you obviously most people needed a testosterone supplement was what the issue was. So Edie, the thing that you're asking there is a good point. There is no age-based normal. Okay. So the fact is that we have this age-related decrease in testosterone is the basis for this testosterone supplementation in men over the age of 50. So what they suggest is that basically 2 blood samples be drawn about a week apart. And again, part of the reason for doing 2 is because we know there are some fluctuations that occur. And the idea was with those 2 samples, basically what would happen is that that would give you an average, and that would be sort of what your number was, and then you could sort of see how much you would need to try to get you in the testosterone levels that a younger man has. So they actually were using younger men as the basis for that. So there was no age-based normal. That was one of the big issues that occurred with regard to that. So there was no threshold serum testosterone that was ever established. And the question of whether an elderly male is hypogonadic is really a question. Is it really hypogonadism? Or is it just that your testosterone levels are normal for that stage of your career? So the normal results, basically, they took on young adult males. So again, the thought process here is that a young adult male, the testosterone level is this. We take the older male's testosterone and move it to the testosterone level that would be equivalent to that of a young male. Because after all, the way the commercial and everything is pushing it was the fatigue and all this other stuff, all this energy we used to have when we were younger, all this virility that we had when we were younger must be due to the fact that our testosterone levels have dropped. So it's sort of like a combination of reversing some of the effects we see with aging. So that was what people went with. Now, when you look at testosterone, and I don't want you to memorize these, but the question becomes is that some physicians will run all 3 of these, determine all 3 of these. Some will just focus on the free testosterone here. So what they'll shoot is the free testosterone actually is the best reflection of what's really available physiologically. Because remember, before lunch, we talked about one of the issues that from a physiological standpoint is that if it's free testosterone, that's the only testosterone that can actually go across the blood vessel and get to the tissues. Okay. We do know, all right, so we can do total testosterone, and that measures free and bound testosterone. Okay. So the total testosterone is pretty much measuring all of the testosterone that you got in your bloodstream. And so if you look at the free testosterone, about 5 to 15 nanograms per mil is what we have. Whereas with total testosterone, which includes the testosterone bound to the SHBG and the testosterone bound to albumin, that is between 280 and 1100. And then the biggest thing with the free testosterone is if the SHBG it can be altered. So if we reduce or increase the concentration of the steroid or the sex hormone binding globulin, that would affect how much free testosterone we have. So that gives us, some physicians prefer the free testosterone. Um, that they think that is the best. Other physicians may want to look at bioavailable, which is basically the amount of the free testosterone, and it measures the albumin bound testosterone. And the reason, their rationale for this is that the albumin really doesn't hold the testosterone as tightly as the SHBG. And so it's very easily released. And so you can see the difference. If you look at total, we may have up to 1,100 nanograms per deciliter. Of that 1,100 nanograms per deciliter, 15 of it, roughly 15, is totally free, up to free. And whereas the bioavailable would give us the free, which may be 15 nanograms per mil, and then another 200 and something, which is outbound albumin. And so the idea is with the bioavailable is the albumin is the albumin bound testosterone is considered, or I think probably my opinion is that the free testosterone basically is what's measured. But if I was requesting something, I might go ahead and do the free testosterone and the bioavailable, although some lab panels will give you all three. So Arnold, as you said, there is that we have to look at when we age, we end up, we get several things that occur that our body normally does, which, again, when we're looking at effects of things or drugs or whatever, we have to consider that, for example, if we're comparing older individuals, they are going to, some hormones like testosterone is going to be lower. Postmenopausal women are going to have a different hormonal profile than younger women. We get older, we lose our sense of smell, as you said, Arnold. Our physical abilities decrease. Part of that is our joints are wearing out. We put on a few extra pounds. Our system is wearing down. So this has created a big issue with regard to a lot of scenarios here. We did see, when people were trying to correct low T, we do see a lot of people would, the clinical trials would suggest this, that people would say, I feel better, I have more energy, my sex drive is increased, all of those things are there. But then again, correcting the low T doesn't come without risk. And one of the big things which sort of slowed this low T thing down was that there was an increased risk of heart attacks, which a lot of the lawyers were going after. And the risk has not gone down. It's just that a lot of the testosterone products are now generics, and it is harder for for a lawyer to sue a generic than it is for them to sue a name brand, because of a lot of the interpretations and issues there. Say those are things that people just need to sort of accept there. And so it's a big issue that comes into play here. And it's one of those issues that comes in, for example, of, is this a true pathophysiology, or is it a drug company induced disease or made up disease? Because some people would say, that if we did normal comparisons, there are a lot of individuals that are, at a low, that do have low T, and they are normal and they're doing fine and they have the energy and so forth. They have more. So it's just one of those things that creates a lot of questions there. You would potentially have somebody that was showing fatigue, maybe even depression and things like that, possibly would come into you and ask, or if you're dealing with people dealing with their sex drive or something like that, those individuals can do that. So, Angela, you asked the age-old question, which drug companies love appetite suppressants because people buy them a lot and doctors will prescribe them, even though we've ran into it. But ultimately, it comes down to when you say, is there anything we can do to prevent gaining weight? As you get older, you're going to basically, your body, the components of your body is going to change. You can have more fat versus muscle. And So the point becomes is that I mean, it comes down to this whole thing is limit food intake or watch what you eat and exercise. Of course, one of the problems that happens is that um, as you get older, it becomes harder to exercise. I mean, I'm 63, and I see myself not one of these people that was going to go to the Y and do the Silver Sneakers program. I don't think that I would even work up a sweat doing the current Silver Sneakers program. I could be wrong. Right now, the fitness thing that I'm going to, I am the closest age to me is a guy that's 56, and but most of them are in their 30s, and so that is, you sort of just, my knee is aching from where I tore an MCL and got some arthritis. But as one of my friends says, is he said, if I'm feeling pain, I know I'm alive. So I guess that's one of the things that you just accept. Okay, so one of your questions coming back from some things this morning. For pregnancy to occur, luteinizing hormone release needs to be A, elevated for a prolonged time, B, FSH release needs to be pulsatile, or C, none of the above. Good. You guys did good. Because what happens is, this was just a little bit tricky because what you would see, and I've used this question, similar question to this, the pharmacy students, and what happens is when they see pulsatile, they go for the pulsatile. But that is true. The luteinizing hormone release needs to be pulsatile in order for it to for ovulation to occur. Let me tell you something interesting, from an example about this pulsatile. So we do use drugs that can influence luteinizing hormone for treating prostate cancer. And so we can use LH agonist and antagonist, or we use actually drugs that affect gonadotropin releasing hormone. And you're sitting there going, so how could I use an agonist and antagonist to get the same results? So if we use an antagonist for prostate cancer, we're blocking the effects of LH, okay? And we're blocking it so that when it's released, it can't have an effect. But the other thing we can do is we can use an agonist. So what it does is it just goes from a pulsatile release to a permanent, to a constant release, or not a release, a constant level, because we're adding a drug on top of that. So here's an example. Because of the pulsatile effects, we can either block the effects of LH, or we can stimulate LH so that it stays constant and we don't get the pulse. So we actually use that in treating prostate cancer, which we probably will talk about years, a year in later on in the year. All right, good job, guys. All right, here's one. Do any of y'all end up treating patients that are dealing with patients with erectile dysfunction that you may be treating or that you anticipate treating? I'm curious with regard to this. Do you get any of these patients with ED? Okay, so there's trauma. Okay. So this is another drug class which you guys might, we'll talk about this in pharmacology, but this is another group that you might particularly end up addressing from that. People that sometimes are, depressed, sometimes that are manic or something like that, can have sexual dysfunction and erectile dysfunction. And so one of the things that we do see is that there's a number of causes for this. For example, we can have damage to the vascular. So what type of diseases could potentially cause vascular problems? Yep, atherosclerosis can do it. Hypertension can do it. What other disease? One other disease that's a big one. Diabetes. There you go. Diabetes. Diabetes can affect the vasculature. And in fact, diabetes can really accentuate atherosclerosis can really accentuate hypertension. And it was not uncommon that somebody will have hypertension, atherosclerosis, and diabetes. So that could be one thing. So one of the things that may help is that in treating this is we may want to see if we can treat those diseases. The neurological issues, let's use diabetes as an example here, is that diabetes can produce neuropathies, and the neuropathies can cause this. The diabetes we can have certain other anything that affects neurological functioning. So any neurodegenerative disease could cause problems. Hormonal, obviously, we're going to have sex hormones that will influence this. And then we can have anatomic, and an anatomic situation is where there may be a lesion. For example, Joy, you have somebody that maybe due to trauma, if it was physical trauma where there was literally damage to either the blood supply of the nerves or the penis itself, these could all result in this particular situation. So one of the first things in looking at this is we've got to consider the concept of what's actually causing it. The other thing I didn't include is it could be back injury is a good thing, but another thing can be this could be psychological. So psychological we had a lot of problems with treatment of prostate cancer years ago. Many of the people treated for prostate cancer, there was the treatment was a surgery, and in doing the surgery to try to remove the tumor or to inject the radioactive pellets could damage the nerve supply or even the blood supply to the penis and create a problem. So one of the first things we want to do is try to determine what the cause is and see if we can eliminate the cause. But again, what I didn't include on here, and I don't know why I didn't, but psychological can do that too. People with depression, people, ED, as you said, PTSD. Those are two things. We can even see it, bipolar patients, especially when they're in the depressed stage. But we can see many diseases that can psychologically cause this. So let's focus on hormonal dysfunction. So what would we look for, or what type of things that could cause this? Well, first one that comes to mind is going to be decreased testosterone. So that could be a problem, so that there's not enough testosterone, and that can result it. But as we said earlier today, we may be dealing with an increased testosterone. A very high dosage could cause this too. And increased estrogen can do that. In fact, one of the things we frequently see is people that are being treated for prostate cancer. We have used estrogenic compounds to treat the prostate cancer. And one of the common complaints they have with the prostate cancer using estrogens is that they lose their libido, and they also can have erectile dysfunction. Increased estrogen to testosterone ratio, so we're making more estrogen than we are testosterone, and even hyperprolactinemia. And hyperprolactinemia can occur due to secondary to drug therapy, which is basically, one of the main class of drugs that we would worry about would be the antipsychotics. It could be due to a brain tumor, which is elevated, which is secreting a lot of prolactin. So those are some things. And again, one of the things we need to determine is it a psychological versus a biochemical or anatomical issue. Anatomically, we should be able to determine that with either examination or potentially an MRI or something like that. When it deals with, if it's psychological, one of the things that they will use is nighttime tumescence. And nighttime tumescence, what they do is they typically either put something around the penis, or they put the old simple way was they would literally take a piece of paper and put it around the penis when the penis was not erect. And the idea is when the person slept, there would be nothing for them to, tell them that they were depressed or whatever. And if they got an erection at night, it would break the paper. Whereas if it's something that is a permanent thing, as we typically would see this occurring, that wouldn't break the paper. The nighttime tumescence would not be there. Typically, we see the vascular, neurological, and even hormonal causes, and even anatomical causes. Those tend to occur progressively over a period of time, whereas the psychological may actually occur more abruptly, unless you have something like trauma that occurs. So these are the things that can cause this. Now let's move to, this is the last group of things that we'll talk about in the male, and then the rest of the afternoon we're going to talk about asking the right questions and going through medical records and so forth. So the other big thing was the PSA, prostate specific antigen. The PSA, when it was developed, the idea was prior to PSA, the main way of examining the prostate was the digital rectal exam. Now, fortunately, in physical assessment, you guys are not going to be doing DREs. That's one thing that you should not probably have to do in your normal practice, even when you get prescribing rights. But many males would not go to the doctor for fear or for just dread of the digital rectal exam. So the idea is that that when they came out with the prostate specific antigen, this was a blood test, which one of the things was this would be we can give a person more frequently would give blood versus be experienced or experience a DRE. So the PSA came out, and I'll tell you exactly what it does. Our values, I'm not going to ask you on the exam, even though this is in red, I'm not going to ask you what the value is, but typically the PSA can be looked at either as a non-age related, which means regardless of your age, we want it below 4 nanograms per mil. But if we look at age related, notice what's happening when you start getting up about 40 to 49, we're below 4, 50 to 59, we're below 4. But then what we see is when you hit in the 60s, we see the upper limit actually is greater than 4. Okay, so in 60 to 69, we prefer it to be lower, but we will tolerate up to 4.5 nanograms per mil. When you hit 70, they will go up to over 6.5. The reason for that is that as a person ages, another one of these age type things, males will tend to develop benign prostate hyperplasia, and that their prostate and its specific antigen actually goes up. So that reflects that that's a increase with age, okay? Now, what PSA actually is, it is a glycoprotein. It's actually a substance which is produced by the glandular epithelial cells that are in the prostate, okay? And that releases, these epithelial cells will release this PSA, and so it gets released into the blood, and we can either, in the blood, we have two forms. We have a free PSA, and we have a complex PSA. The complex PSA is PSA that's bound to some compounds in the blood. PSA values will fluctuate daily. And so typically what we're going to want is if we see an increase, so we're above that 4, let's just use the non-age related. So if I go in and I give a blood and my PSA is above 4, then typically what's going to happen is they're going to want to repeat this, okay? Now, keep in mind that the PSA has never completely replaced the digital rectal exam. So if typically what you see now is that when a male goes in for a physical, his annual physical, that we frequently will see where that the doctor will go ahead and do a digital rectal exam and pull a PSA. So we usually have it. But if the PSA comes back in abnormal, they're going to want to do another sample. Now, another thing that happens is that over the age of 50, there is another test which for both males and females that is advocated, and that is a colonoscopy. So one of the things is sometimes, the guy goes in for a colonoscopy And since they're going to pretty much pass the scope, you know, right past your prostate, then usually you're not in double jeopardy. So the year that you have to get the colonoscopy, the right thing to think about is that you're not going to have another DRE probably. So the colonoscopy can actually visualize the prostate and can determine if there's something there. So, but if I you know, the doctor feels anything unusual, or if your PSA comes back higher than 4, then they will probably want to do a little bit more testing, which means probably another blood sample. What we find is that people that are obese, and of course people that have hypogonadism, is their PSA values tend to be low. So you know, one of the things that happens as you start getting older is that you put on more fat, and if you get to that obesity, this you know, this you have to take this into account. The other thing is, like I said, is as you age, one of the things after the age of 50, males tend to be subject to developing what is called BPH, and that is benign prostatic hyperplasia. Okay. There's some new data out that suggests that, you know, that these BPH does not predispose you to prostate cancer. Okay. But we do see as men get older that we are seeing that there's more BPH, that BPH, you know, it's estimated that men over the age of 50, that probably at least 50%, probably more, will experience or will have BPH, which basically means that your prostate starts enlarging. We see also that the PSA values are a little bit higher in African American males, greater than 60. So as we start getting older, the data that's come out is not only that one of the reasons we get the you know, have the higher values is that we may develop BPH, which is going to contribute to the PSA. So the big thing is what we're looking for with the PSA really comes down to, you know, from a standpoint of we're looking at it as a tool to identify if there may be changes in the prostate. And in particular, is it a marker that we have a tumor in the prostate? Okay. So it is actually serves as a diagnostic tool for picking up prostate cancer. Now, the new norm, if you will, is when people used to get prostate cancer or develop prostate cancer or have signs of prostate cancer, then basically there was a pretty aggressive treatment. So typically what would happen is that the individual would potentially, you know, have to do, have some MRIs done, but more importantly, if they would possibly want to do biopsies, and even the biopsies can be very painful. A friend of mine who passed away about a year ago that with prostate cancer was describing it in a talk he gave, and he said they took 16 or 18 biopsies, and his comment was, in these 16 to 18 biopsies, it's a situation where it feels like you have a wasp up your rectum and it's stinging you each time. Kiara, from a standpoint on the variation, is it's intrapatient variation. So the same patient, the PSA level can move up or down is what you have to worry about. So that's why what we look at more importantly now is a rate, but a rate of change. But what we see now is there's this thing called, have you guys heard of watchful waiting? So watchful waiting is basically that instead of jumping in there and being aggressive with some of these PSAs or some of these prostate cancers, is one of the concerns is that some of the biopsies and things like that we're doing, really we could miss a lot, and that some of the procedures that we were doing were so aggressive and created actually affected quality of life significantly. And so now what we see is that we don't see people quite as aggressive. I think we have some other drugs that are coming out here that are even better. So now if someone is diagnosed with prostate cancer, we use PSA as a tumor marker. We do it, number one, as a screening tool. It's part of our screening tool. And then we also, that once somebody develops it or has been diagnosed with it, then we use it to monitor response to therapy, okay? So what happens is it's got a pretty high sensitivity. So it is the chance of picking it up pretty good, but the specificity is low. It could pick up other things there. So the issue is, there's two things we've learned about PSA. The higher the values, which you really don't want, the more predictive it is. So for example, when you are when you're between 2.5 to 4 nanograms per mil, the chances of it predicting cancer is about 18%. So it's very, very low. When you get up above 4 to 10 nanograms, it kicks up to 20. But when it's above 10 nanograms per mil, then it's 42 to 64%. So even with that, one of the things the PSA didn't quite turn out to be as viable as we really wanted it to be. What we've discovered is it's really not the best situation for just using it alone. Initially, when it came out, I think a lot of people looked at it as this would completely replace the DRE, the digital rectal exam. But what we've come to find out is we need to use it. So you take the PSA coupled with the digital exam, and when you use the combination, it has a pretty significant increase in the predictive value. So now that's what we have. We do know the use of PSA resulted in patients being diagnosed much earlier. It's estimated that, depending on the study, that the patients being diagnosed with using PSA, they're now diagnosed 5 to 13 years earlier than what they used to be. All right. So let's ask, make sure this is the, all right, so going to the next question, here's your next. Decreased albumin or SHBG would produce a state of low T, true or false? Okay, the answer is false. When you decrease albumin, that means there's less binding, or you decrease SHBG, which would mean there would be more free testosterone. So we could still have low T, but that would, the chances of it, depending on what we were measuring, that would not produce the low T itself. We may have more, by having decreased albumin or SHBG, we would have more free testosterone, but it's not going to produce the state of low T. So you guys did a good job. Okay, going back to PSA. So using it as a tumor marker, when it's less than 10, here's what we look at. So if your PSA is less than 10, typically it's above 4, but less than 10, is that that means that the cancer is really limited to the prostate, okay? And so that means if you, typically if you do have a cancer, that it's still localized to the prostate. But the PSF level goes up and it's between really 10 and 20, but still less than 20, then it is probably moved to the extracapsular space, which is the outer portions of the prostate. And then when the PSFA level gets up above the 20 and is less than or equal to 80, then that's you got a pretty advanced disease. So sometimes watchful waiting will wait to see until it moves up to at least the extracapsular space. When we start treating, what we are expecting is that if we've got successful treatment, then we expect the PSA levels to drop back down to the normal range. That would be ideal. But if it doesn't go back to normal, successful therapy would still be looked at as if we had a twofold reduction in the PSA. But ideally, we would like the PSA to be back down to normal. But if we get a twofold reduction, that means the treatment is actually seems to be working. And then the last thing here is what they do is they actually combine it with what is referred to as a Gleason score, which is another thing to which comes into play there. Does anybody? I'm sure you've probably heard of a Gleason score. Does anybody know what a Gleason score is? By any chance? So what happens with the Gleason score is this is just a way of rating it. And so what they do here is they the Gleason score is basically it's a grading system for how aggressive the prostate cancer is. So what they do is based upon the Gleason score is that sort of determines how aggressive they're going to be to treat the cancer. So to give you an example here, Gleason scores basically looks, what they're taking is they do a biopsy. And with the biopsy, what they're going to do is they look at the, if the tissue is healthy, the lower the Gleason score, the better you're off. So what we see here is that typically is a typical Gleason score is between 6 and 10, okay? The prostate tumors basically have different cells that are cancerous, and the cancer cells are really come into play what is how aggressive the case is. So from a standpoint of the higher the Gleason score, the more likely the cancer will grow and spread quickly. So when we look at this, they take the cells that make up the largest area of the tumor, and then they give a secondary grade to the cells in the next largest area. And so the Gleason score sometimes will be written like a 2 plus 5, which equals like 7. All right. So the tumor would be a grade 2 of that example, and then the next section of the tumor would be 4. And so if the cancer is almost completely made up of cells with the same score, then the grade for that area is counted twice. So if they look very similar, it'd be 2 plus 2 would be 4. So what we see is that scores of 6 or less describe that there's cancer cells that look very similar to normal cells, and that suggests that the cancer is going to be growing fairly slowly. Okay, these are the type of scores that when a person has a Gleason score like 6 or less, these are really the ones that they look at more doing the watchful waiting. When you get to 7, what that means is that's sort of considered an intermediate risk for the aggressiveness of the cancer. And typically that means the largest section of the tumor was usually a 3 or a 4. And so if the primary score is 3 and the secondary score is 4, they consider that a fairly good outlook. Where if you see the primary score, the biggest part of the tissue is a 4, and the secondary score is 3, that one is more likely to spread and metastasize. And scores 8 or higher, basically those are considered the aggressive cancers, and those are considered what we refer to as a high-grade score. So what they do is when they're looking at that, they take the Gleason score, and that is one thing they use, but then to determine it, they also look at the PSA level, which is what we're talking about here. They will take the findings from the digital rectal exam, which is the description of what the prostate felt like. If there is biopsy scores done, see, that's one thing on these lower scores, they may not do these biopsies as quickly. So what they do is they'll take a number of biopsy cores. So it's not like they just go in and take one biopsy, they take multiple cores, and then they calculate or figure in the number of biopsy cores that actually have cancerous cells. And once they look at those core samples, what they do is they determine what percentage of the core sample is a cancer cell. They also want to know, is the cancer present in both sides of the prostate? And they also want to know, is there any evidence that there's the cancer is spread outside the prostate. So example, somebody coming in with a lot of bone pain, that would suggest that potentially the cancer is spread into the bone, which would not be good. So it's sort of an interesting thing with regard to how they do that. And the issue is that these slow growing cancers, the new thing is watchful waiting. However, you may run into some patients that may have a lot of anxiety about watchful waiting. There's people that when they are diagnosed with the cancer, they want to get it out, and any thought that the cancer is still there creates a lot of anxiety and depression for them. And there's other people which can handle it. And that's one of the concerns with the watchful waiting, is simply that some individuals just can't do that, can't handle that. A couple other things. There is what is called the PSAD. This is actually taking the prostate volume, which they do using a transrectal ultrasound. And what it does is it calculates the prostate volume and puts a ratio with the PSA score. And the biggest problem here is that the cutoff that they use has been estimated that it could miss up to 50% of the patients. So that, even though that's calculated, there's concerns with that. What we typically see is looking at, as I said, rate of change, and it's called PSA velocity. And so that looks at the rate of increase in the PSA over time. So the faster the rate would suggest that if the PSA is going up, then the faster it goes up suggests that that's a cancer. So what they do is they basically have to take 3 PSA values, and these are either about a year apart, but at least so you'd have 3 PS value that are a year apart, or at least over a 1.5 year period. So if these PSA values exceed 0.75 nanograms per mil per year, notice that's a rate change, that suggests there's a prostate cancer, that something is growing. So what they suggest, if you're less than 60 years of age, they're suggesting using a threshold of about 0.4 nanograms per mil per year. But we do see that sometimes with variation, this is one of you asked me about variation, Kiera, I think you did. So one of the things it sees is because of this variation in PSA, that they sometimes will look at a doubling time, which is simply how long it takes for the PSA value to double. And some people have suggested using that, but they don't have a standard. It's not really been validated or vetted to that. And so the question is what I'm saying the standard is, they really have not determined what's the minimum number of samples to use or what the time interval. So for example, if someone were to take, a much, much shorter time, let's say we took a PSA value today and a month later took a PSA value, then we may not see a change. Whereas if we were taking it, once a year, we may see a significant change. So people have been still looking at ways to come up with, with trying to diagnose and treat prostate cancer. The main thing that again, is with prevention. And, one of the things, as you're doing a physical assessment, obviously you're not going to be doing a digital rectal exam. It's possible that I would be even cautious about running a PSA because you would need to be able to interpret it. But what you can do is you can tell your male patients, especially those over 50, one of the things that you can tell them is that basically it would be wise for them to have an annual exam. And again, it's very important for you to stress to, the patients that you're dealing with that you are not doing that annual physical exam. You are doing a physical assessment for your main purposes. So it's a very limited physical assessment. Okay. All right. So we're at a good place to take a break. Let's come back at 25 after the hour. Get a good stretch. I'm going to change slide banks. We're going to go to the second slide set. And then we're going to start talking about medical records and part going into taking vitals and stuff like that. But those will probably occur. The more vital stuff will be taken tomorrow, is I believe. So I'm hoping that y'all have gotten a stethoscope and a blood pressure monitor, and at least because we will definitely need those tomorrow. There'll be some times when I'm going to have you take blood pressures, so it'll be like I'm going to have you do something, go take blood pressures, and then come back. So you will have some time for that tomorrow. Okay. All right. So let's come back at what time did I say? 25 after the hour, and I'm going to go ahead and load the next slide set. And let's go ahead and get started. Aiden, I'm going to send you probably at our next short break, which will be in about 45 minutes maybe. I'm going to send you or send you a thing of videos for tonight. So tonight for your homework is I have two videos. One is from a guy from Johns Hopkins that talks about medical chart review, which I think he hits some good points. That's a little bit long. It's about 30 minutes. And then there's another shorter video I'm going to give you that was actually written from produced by a nursing group that basically talks about some of the errors that's associated with charting and things like that. So I do realize that many of you have had extensive experience with this, and I do realize that several of you have had some of the stuff we're going to cover on this. I think this is the second slide deck, if I remember correctly, that we're going to cover. Some of you had this, so just just try not to roll your eyes too much so that I hear them. But it's important that we go over it. It's got to be covered in the curriculum. And again, one of the nice things about this class, this one class, is that it's not doesn't appear to be as material rich, if you will, which we will get a lot. You will catch up on the material richness next semester with pharmacology. So you'll be wishing it's in a sense for this course probably. So I apologize if we're going to bore some of you. Again, as I said this morning, that any of you that have some suggestions or whatever, feel free to things that you've learned or someone has taught you or that you've developed that helps you in your practice. Please feel free to share those in this material here. Okay. So we're going to go through pretty much charting. And as I told you yesterday or this morning, is that even though we're going through this charting, and I know you guys have written SOAP notes, is tomorrow you will have a case, which I'm going to have you write a SOAP note up, and we will be doing some vitals tomorrow. So I decided not to have you guys do the SOAP note tonight. One of the reasons was I was hoping that we would do pretty well with this with Zoom today, and so I was afraid that if I just took it for granted, it would catch up on us in the future. Now, I don't know what your experience has been on each one of you, but I have reviewed medical charts, especially from a legal standpoint, for close to, let's see, it's looking at over 30 years now. And I think the realization, and also when we're teaching, especially our pharmacy students, although we go over a template with the SOAP notes and what's in each area, this is something that varies a lot. One of the things that I have discovered, which my naivete went completely out the window the first time I did a project reviewing medical. And I just thought that medicals, especially where I was going to be doing the review, I figured they would be computerized. It would be very easy to sit down and, just pull everything I needed to know. And what I discovered in my first project that I did was is that everything that I needed from medical records, I had to give them a good lead on, that I would get the charts and then find out that, for example, there would be a section of the charts missing, and I would find out, oh, well, this department pulled that section, and so that chart is over there. I found trying to pull out certain data, I was very naive with regard to going to where I thought it would be and finding out that it wasn't there, and then finding out I was reading through page after page after page to try to find some notation and finding out that it was stuck here and there. So if you've had that similar experience, it can be very frustrating. If it's, your own patients, or like when I was doing studies, is my data is set up, or mine was set up, what works for me. But one of the things about medical records is there has been at least an attempt to try to standardize where things are. But even with that attempt, there is no medical policeman that goes, or no policeman that goes back. And, the biggest thing is if, there's some people that are going to put it wherever they put it, and you just have to find it. So let's go through the different sections. And again, some sections we'll move through pretty quick. But one of the things that's pretty important is the history of present illness. As we go through these medical records, we're going to point out some abbreviations, some of which you may be aware of, some of which you may not be aware of. One of the key points here is when we're talking about the medical records, one of the main concerns that we want is we need an accurate history. This is essential, an accurate history. Unfortunately, that accurate history can create, what you run into with the history is going to be basically, well, let me ask you guys, what creates problems with getting an accurate history in a patient, in your experiences? Boy, Edie and Jason, you guys hit it really quick. So poor historian, patients lie, memory, okay? Anything else? Faulty memory, not asking the right questions. Excellent. What else? Patient are intentionally or unintentionally dishonest, correct? Emotional distress, shame. Yes, exactly. What else we got? So let's talk about that, some of these things, because I think you guys hit some excellent categories here. One of the things is ultimately, Jason, that's another good one we're running into more and more, different cultures between the patient and clinician. With not only with cultures, but with sometimes with individuals, that are over here on visas, the concern that giving the wrong information may get them deported or create a problem. Withholding information. Yes. Okay. So let's talk about a few of these to begin with from a standpoint of all right. So one of the concerns is, I'm just going to start at the top. So a poor historian is somebody doesn't remember everything. Maybe someone else has been in charge of taking medications, are a good example. Or from a standpoint of historian is someone is taking and interacting with the clinician at one visit or another visit. And so that person, the actual patient, really is sort of out of the loop. Sometimes we create that because the point becomes as a clinician, what happens sometimes is we don't engage the patient, so the patient doesn't really know what's going on. Sometimes the poor historian is because the patient, certain things may have been kept from patients. For example, it may be that there's a poor prognosis or a condition or something that they don't want the patient to be aware of. This is particularly a situation with older adults and sometimes with young children. One of the thing is when you got historians, what about competing historians? Has anybody had any of that problem? One of the issues that you run into is that the spouse may give one account, one parent may give another account. There you go, Jason. There, pediatric cases. Those are things, and sometimes the differences can be from their perspective. That's an issue that comes into play there. Cognition deficits. That is a big issue that comes into play, is especially one of the things that maybe happen when some of these cognitive deficits may be emerging. So the individual may not recognize, as a person is aging or a neurodegenerative thing is coming along, is what happens is the person is not remembering things, or is may not at one visit remember stuff. For example, somebody that may be having an emerging situation where you see them may be at a different situation. It's very important, Janelle, you bring up a good point here, is being able to develop a good rapport with the patients. And actually, one of the things that is very good about your situation is that you, as of all the healthcare providers, to me, psychologists have one of the best skill sets for getting information out there. Janelle, you brought up another thing here. I have a good friend. It was funny because she is a take charge person, and that is the one thing my wife his birthday is tomorrow, and we took her out to dinner last night, and our good friend went with us, and she is a sort of a take charge mothering type person. She's widowed and she has a son, but she sort of lives by herself. And one of the things that we run into that I have to grate is, like, we walked into the restaurant and we got a little bit early, and I said, let me just check and see if they can take us early. And so I walked up to the receptionist at the restaurant, or the concierge at the restaurant. And before I could even open my mind, this friend is basically asking all the questions and taking charge. And I was the one that set everything up, and I was just having to grit my teeth. When they came to the table to ask us what type of things, we were at a fondue place, and she would just take charge. But that's one of the things that could happen, is that sometimes the person sitting there can influence what the other person may want to say. There can be issues where the person doesn't really have the perspective, but is the take charge type person. Sometimes we have, a relative that comes in from out of town because there's been sort of a serious situation, and then they start interjecting where they may not really know what's there. Hearing deficits, big thing there. Hiding from insurance or trying to get around insurance, yes. Social Security, disability applicants. These are all important things which can greatly affect for example, the person may come to a doctor and give a complaint, or come to a healthcare person with a chief complaint of something, but the idea is there's actually another issue that is going on. And the idea is that they want to come in, but they don't want to present with that. Let's see. Failure to recognize certain signs and symptoms as significant. That's an important issue, because sometimes fits in with some of these other things. Is maybe to them recognizing a sign or symptom, for example, a pain may show a sign of weakness, and they may be there for another reason. So that's it. There are people that, in particular, one of the things we run into a lot, things dealing with drug, alcohol, and sex, those three things may or may not be given to you correctly, or may be given from a different perspective. I had one chart we looked at, the patient, their statement was that the wife said he was a moderate drinker, and the guy was drinking I think it was around 8 to 12 beers a day. And, when we were trying to reconcile this, well, to her, a heavy drinker was somebody that was drinking, there was a person that she knew that was pretty much drinking like about 18 beers. So in her perspective, her husband was a moderate drinker, plus his, his stance in the community and everything like that. All of that, if he was considered a heavy drinker, that would be bad. So they classified him as a moderate drinker. So that was another issue there. Let's see. As far as withholding information, sometimes, for example, they may not want you to know, or their doctor to know. For example, their GP, they may not tell them they're seeing a psychologist. Another thing is, as that we've run into this too, is that sometimes if you're not an MD, you're not a doctor. So anything they talk to about anybody else that doesn't have a quote MD behind there, their name is not considered a doctor, so they won't give that information. If they go to see multiple doctors, they may not want to tell you that they are seeing other doctors for fear that you will either be jealous or that, you won't treat them. Let's see. Emotional distress, and part of emotional stress may be a different perspective. We see a lot of different things there, concerns about, defects, whether if they reveal something about the children or give you the reason the child got hurt, they're concerned about, defects. So we see a lot of these things. And a big thing is, since we are going to build on this history, it's important that we get an accurate history. Now, you've got one other thing here that you haven't mentioned, and it's all of the things that you guys have mentioned are excellent, absolutely excellent. You hit some areas I didn't think you would. For example, shame. That's one thing that in working with, you guys have not had the benefit of Dr. Norton yet, but Dr. Norton will probably teach you all about drug addiction. He and I work a lot together, and we do deal with a lot of different students that have addiction problems or drug problems. And Dr. Norton has gotten, one of his big things is that in treating people with addictions, shame is a big issue. Shame may be an extreme issue when dealing with somebody with bipolar, things that they may have done when they're in their manic state and so forth. But one of the things to keep in mind with regard to this accurate history is not only is it important to get this from the patient and to capture this in the history of the present illness, but another thing is that it's important that accurate history gets carried on. So one of the things that can happen is there can be transcribing errors. And sometimes those transcribing errors can actually be propagated. We were working on a law case that dealt with a drug that produced Stevens-Johnson syndrome. So when the individual came in, the individual actually had 3 mosquito bites on their cheek. And the 3 mosquito bites was the reason that the mom gave the child a particular drug. And but when it got transcribed, what it came down to was that the mom had given the drug, instead of it being 3 insect bites, it came down to 3 bumps. And so what happened was the case was and even in treating the patient, that the clinician was not aware and excluded the drug being the cause of it, because what it was that the 3 bumps were mosquito bites or insect bites. The mother gave this, and then the person developed a lot of bumps and pustules and blisters. So as it was transcribed, it was like 3 bumps or 3 blisters appeared on the skin, which meant that the doctors reading it down, in fact, even the dermatologist said, well, it wasn't this drug. I excluded the drug because the blisters had occurred. And there weren't blisters. It was basically 3 bumps. So not only do you have to worry about it, you have to be careful, is this accurate history is going to be very important. One of the exercises I give to my forensic students, which is sort of funny, is basically I will give them an autopsy report, and one of them says this. The one that I give them says like this: that this was a 4-year-old female with a well-developed penis. So they're sitting there and they're going, and I'm going, so here's an issue where obviously there is something wrong here. And the reality of it, it's a transcription error. Kirsten, you bring up a good point down here, is that not asking why someone takes the prescription and making that an assumption of why they're taking this, especially with an off-label use. You actually use the imipramine for incontinence versus depression. So that is an important thing there. And the other thing along this way here is making the assumption that this is a prescription that the patient has. We see a lot of people that are taking prescriptions and they put it down in their medication history. And when you work through the case, what you actually find out is that it is not the patient's prescription. In fact, what it is somebody else's prescription. It was never prescribed to the patient. I just dealt with a patient history I was reading here that he put on his thing that he had an addiction to OxyContin, and went through and was saying that to prevent withdrawal that he had Suboxone, blah, 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 and going on down. And as I was going down through the thing, I was like, all right, so who prescribed the Suboxone? Well, the point is that nobody prescribed the Suboxone. He was self-medicating, and he was buying off the street Suboxone. Sometimes the Suboxone would be in the original package. Sometimes Suboxone was what somebody told him was Suboxone, which we're not sure if it was or not. So we can see these type of things, or an individual may mix things up because it's just from their understanding, they may confuse it with something. So drugs that sound alike can sometimes be confused, or the way a person may, you may ask them and they'll try to say something, and then you try to help them out, and when you say something, they'll agree to that, and it may be an entirely different drug. So that's another thing that you have to be aware of. So getting that accurate history is going to be very essential, because you're going to base a lot of things on that history. Okay. So to get that accurate history, and you guys have touched on a lot of these, is basically we have to get the relevant data from the patient. One of the things is that what relevant data are we getting? We may not know. Some of the questions that we ask may reveal to us what type of relevant data that we are looking for. So the question is sometimes we make the assumptions, like, for example, Kirsten, seeing imipramine, and especially several years ago, imipramine was, we see imipramine not used as much as an antidepressant so we have other drugs that are being used, but we also see a lot of off-label use that occurs that it may be entirely for something else. So to get the right information from the patient, the baseline you have to start off with is going to be, number one, is understanding basic pathophysiology. We had covered several things last semester, or last class, on clinical medicine, some of which you may be sitting there going, I'm not treating a patient with this. I'm not treating a person for their high blood pressure. I'm not treating a patient for this kidney disease. I'm treating a mental type case. But the point is that some of the things, that the pathophysiology that may be involved may have an impact on that person's mental state. The pathophysiology may have an impact on what drug you can give them. And sometimes the pathophysiology may be something that you may have to differentiate. For example, with depression, you need to differentiate. Could it be some of the signs of depression? Could it be an anemia? Could it be hypothyroidism? Could it be something else? The other thing is, and this helps you in many cases, is it also getting the information is sort of like getting to know your patient population is dependent on your experience and exposure to patients with certain specific illnesses and comorbidities. Each of you are in a particular practice right now that you probably see a group of the same docs prescribing or treating these patients. And in fact, our pharmacists learn pretty quickly. They know that if Dr. Smith is treating the patient, I can pretty much tell you that he's going to start the patient on this, this, and this. And in fact, in our pharmacists, if they see a prescription from Dr. Smith that is different, they question it sometimes. So if Dr. Smith is always prescribing, for example, Xanax, and they get a prescription for Valium or a prescription for maybe Klonopin, some of our pharmacists that have been around would actually pick up the phone to call Dr. Smith just to make sure there's not something going on there. So when you move to a new area, sometimes you have to get used to that. And so, but you will see, I would be willing to bet that many of that, just in asking questions I've had over the time that I've known you guys, some of you are in certain practices, you're familiar with formularies. For example, we frequently have people that work in institutionalized patients or prisons. And so they will tell you, you could almost tell you that in their prison system, this is going to be the standard of care, because this is what we have on our formulary and that's what they treat them with. And some of you have struggled with that because you know that there may be a better drug. Some of these patients that have limited, that come to the clinics and so forth, may be limited to what they can treat those patients. So that's part of that experience and exposure, and finding out, getting a good feel for that. You guys typically have this. It's not what we see in every healthcare provider, which requires good listening skills. Pharmacists have good listening skills, but in a very busy time, one of the things they're juggling multiple things, and those listening skills may get pushed back. Used to, I don't know if you guys remember this, but pharmacists used to actually be kept away from the front counter. They were actually put on like a, where the pharmacist actually worked was raised up, and it was physically moved back from the counter. So they sort of overlooked everything. And the reason that was done was to reduce the distractions from the pharmacist. So one of the things sometimes, as your responsibilities and your patient number increases, one of my friends works at a physical therapy thing, and she's just started there. And she was telling me the other day that a physical therapist, which has got maybe 3 physical therapists and then maybe 3 or 4 technicians, they've got coming up this next week like 70 something patients per day, for starting off with the day, and that includes a few new patients. So patients coming in, and you all know the other thing is sometimes those good listening skills get really taxed, especially when you have somebody that's coming in that is basically wanting to tell you their life history and go off on tangents, or doesn't want to deal with you. Basically, you're a barrier. All they want is get their medicines and get out of there, and you're making them tell them about making sure you're checking on side effects. So that creates issues that we have to deal with. Okay, let's go to same thing. So not only do you have to listen and to get this, but one of the things is framing those questions so that you can help the patient define the nature of the illness. Children and geriatric patients sometimes have a problem with framing the symptoms or their natures. Sometimes we have cultural differences in how things are explained. And so one of the things is trying to make sure you're listening and do follow-up questions that help the patient tell you about the symptoms and stuff. At the same time, you have to be careful about suggesting things to them. Okay? So that's a real skill, and you gain it. Many of you have already got that skill, but now we're putting you into a new realm with regard to getting some other information, because you're choosing to take on some additional responsibilities. And so now you need additional questions. What type of questions or what type of subjects do you find that in the patients that you guys deal with, that the patient has a hard time defining the nature of the illness or defining a symptom? What has your experience been? Chronic pain. Okay. There's another chronic pain. Mood lability. Good one. Flashbacks. Dizzy. Jason, anything's that good. Depressive symptoms. Okay. So, the other thing that you run into, and many of y'all hitting some good areas here, the other things you run into is sometimes that someone else has told them what their symptoms are, which someone else has an interpreted for them. This can be, a caretaker. This can be some, especially with kids, the parents trying to say, oh, well, this is what happens or whatever. So Um, those are all things. And then Rebecca, you mentioned that Google. That's another question is if somebody has gotten on Google, and here's an issue that I've seen is that someone gets a chronic pain or someone gets a symptom. So they look up on Google, and then they start. The question becomes, Google may identify a condition, and then they sort of chase the rabbit down the hole, which is Google starts giving these symptoms for these other things. So then there's a question with regard to that they're developing it, and sometimes psychosomatically they may develop the symptoms, or sometimes they may feel like they've developed those symptoms, especially if it's very subjective. So that is, sometimes there is questions, and again, it's a very fine line in being able to talk to the patients. I dealt with a woman this week that she's in the office, and she was trying to tell me, she said, I need somebody to review my medications for me. And I said, well, I'll be glad to do that. And she said, well, I just don't know I'm afraid that if I let you look at my medications, that you're going to, it's going to change how you think of me. And I'm going, it really isn't. So my immediate thing is that, thinking what would make a person do that is sometimes if they were taking, let's see, something, an antiviral, because they may have AIDS, or they may have some, whatchamacallit, sexually transmitted disease, and it turns out is that this person, her husband had died, and her general practitioner had given her an antidepressant, which she learned to find out it was really an antipsychotic. So the problem was she thinks she's taking that she has psychosis, and the problem is that she's gained weight. And so the question is the physician has never checked her to see if she's never been diagnosed with depression. What she had was she was depressed after her husband died. And so the point is that she was afraid to have anybody. I mean, here she's in a college of pharmacy, and there is so many pharmacists there, and I know her pretty well. And so that's why I said, well, just let me look. And she never would tell me what her medication was. And I sort of like a guessing game. But the problem is sometimes they will get a little information from you, and then they will want to Google. And so the big joke around a lot of places is, who do you see? Well, it's Dr. Google. The other thing is not only Google, but I tell my students to look on the tabloids that are present in the supermarket. And the reason for that is because a lot of patients will come in, they'll pick up a symptom that they saw in the National Enquirer, and that sort of thing. So typically what's going to come in is the patient is going to initiate the history of the prognosis, but basically usually describing a symptom, okay? And sometimes those symptoms can be very ambiguous. Sometimes they can be very specific. One of the things, the main reason the patient is going to come to the clinician, this is what we refer to, and you guys know it is called the chief complaint, okay? And with the chief complaint, this is important. And on the video tonight, this guy makes a good point about the chief complaint. Here's what you have to remember. The chief complaint may not be the most important thing that needs to be addressed in this patient, okay? There may be a more serious condition that's there. You may have somebody coming in and saying, I'm fatigued. You may have somebody coming in saying that I can't sleep, and that's what's bothering them. But the most important thing you may find out is that person may have severe mania. The person may be severely depressed. There's a lot of different things that could be there. It could be a drug interaction that's occurring. So from a standpoint of the chief complaint is why the patient comes in. So you would write it up as that's why the patient comes in complaining of this, okay? But the important thing is, right, as you go through this, you've got to identify the things that are the most important. But what you also have to realize is the things that is bothering that patient the most is why they're there. So, for example, the patient comes in and they may say, like I said, I can't sleep at night. And somebody may want you their impression is just give me a sleeping pill and I'll be fine. But in working up the patient, what you may find is that the patient, A, may not be a good candidate for the sleeping pill, for a sleeping pill. B, a sleeping pill may actually not work. C is there may be a more serious underlying problem that you need to address. So, so Jason, you say patients who don't ever go to a GP but take the kids to urgent care when they need something. So that's a good point. When we're talking about the medical records, in an ideal world, it would be great that we had a central bank that we could access everybody's complete medical records. I'm dealing with a drug interaction on a patient right now, which the question is whether it's a true drug interaction. But one of the things is this patient supposedly has had a heel Achilles tendon tear from and is blaming it on an antibiotic. But the point is that the woman starts taking the antibiotic like a month before this occurred. And in her chief complaint, she's got that she has visited multiple physicians for this pain in her heel. And so as I'm tracking this down, what I'm running into is the multiple physicians when I'm getting piecemeal from her. But the first thing is she went to her OBGYN, which she's 60 years old. So it's really her gynecologist. And I'm going, so how did the gynecologist treat your heel? We haven't got the answer to that. So we're still, it's like gathering thing. Did she ever go to an orthopedist? We don't know yet. She hasn't told us yet. We just got some of her medical records and there's a blank, one of the things that we see is our pharmacy records. And one of the things we see is that there is like 2 years of it missing. And she says that's all of her records. But apparently for 2 years, she went to a different pharmacy. So we're trying to determine, we think she's taken the drug before without any problem. So it is a big issue there when you're trying to do that. And urgent cares are getting more frequent to get in, because one of the things we're running into is people trying to get in the GPs has become more difficult. So there, being able to get access records even to help develop this, and also, a caregiver bringing them in may come in with a different problem than what's really working. So, for example, in a wheelchair-bound or a bed-bound person, they may come in, the urgent care or the caregiver. The thing may be that they've had increased frequency, increased urination. They're wetting the bed or having to carry them to the bed. And so you may be thinking UTI, but there may be other things that are involved that we don't know yet. So that's another big thing there. So getting pharmacy records, getting medical records. Also, we're seeing people move around quite a bit. And Joy, we are seeing some that are doing that, but again, also people are in today's times are very nervous at who gets their records from a standpoint of that. By the way, let's take a break. This will be our last break for the day. Let's take about a 6-minute break. When we come back, somebody remind me to tell you something about CBD. There's something that came up this week. It's a little off. I'm making myself a note. It's a little off topic, but it fits in with what we had the other day. Rebecca, if you're moving from Florida to Pennsylvania, you do need a psychiatric evaluation. I just had a niece that moved up, and we tried to tell her that it snows up in Pennsylvania, and she never believed us that it snowed up there. She is now discovering we were not lying. So, but I think everything will be on Moodle with regard to it'll be 2 videos. It'll be a link, and I'm going to send them to Aiden during this break. So let's come back to let's come back at 10 after. Okay. Got it. Is that so there, you guys are familiar with the new drug that was released that is the cannabidiol oil Epidiolex. Have you guys heard of that one? This one was just approved by the FDA. It's the first CBD, cannabidiol plant extract, pure oil. It's approved for 2 rare forms of epilepsy. But just to be aware of what you need to be aware of is when they extract CBD from the plant, they cannot extract it completely free of THC. So it's not in the package insert, but it's in the patient guide, so that people that if they took this, theoretically they could test positive for a cannabinoid test for marijuana. But I talked to a company rep about it this week. We were talking about different things, and they were straightforward. And I said, "Well, did the doctors know?" They're really not worried about it too much, because they said the patients that would be treating this probably would not be working and would not be holding a job, nor would they be driving. So they don't have to really, they're not thinking it's a big worry. The other thing is that it is so expensive that they believe it would be cost prohibitive from a standpoint of somebody using that. My biggest concern is with it is if it goes off of being used off label. Excuse me. I was looking to see if they had the pricing here, because I actually had a graduate student that did some calculations, and I don't have his numbers, but it's several $100s. It's pretty expensive. So, anyway, we don't know, Jason, we don't know the exact mechanism of CBD right now. I've got some stuff which I'll try to get up, and let me see if I can. Thanks for letting me know. I don't know why it's should be. I don't know why it's doing that, Eddie, but we do it. But anyway, it's Epidiolex is what I put. But anyway, we know some of the mechanisms, and there's some things. But if you will let me know, Jason, I'll try to get you some information, or we'll try to get some up there. So that's one of the things we need to know too, is that that's a good thing. We need to just make sure, because I'm still showing Edie it's going directly to you as a private, and so we'll have to. There we go. All right, that should take care of it. Thank you for bringing that to our attention. So those of you be aware that it's easy to ship when you're on the chat board. It's very easy to flip it over to where it's going to private messaging. So I had to go up to the more to make sure. So that may switch it. So just be aware that when it's there. So if I respond, basically, if one of you gets it only private and it looks like it's to the rest of the class, just let me know. But anyway, for the CBD, one of the things, again, I don't think it's an immediate problem, but as we get more drugs that are plant extracts, is right now they cannot completely extract it THC free, and I think that will be it. But I can, Jason, I do have I've actually done a lot of talks on marijuana and that sort of thing, and so I can get you some information there if you'll send it to me. It'll be later on in the week, but I can just remind me. Okay. All right. So let's move. I know we've had a couple of people that, what I'll try to do is, maybe if I can get some of that information, I'll just see about putting it, see if I can put it on Moodle or something like that. And so you guys just remind me. And if I don't put it on there later on, I'll make myself a note. But you know how absent-minded professors get. All right. So let's move through a couple of things with regard to questions, which these we can move pretty quickly. And I know that there's a few of you that have had to leave or fixing to leave. So like I said, the videos that I've got are going to take about 20, 25 minutes. So I was going to try to let you guys out by around 6:30 so that you would have time to look at those videos. So with fiscal assessment, it's very important. And some of these are pretty straightforward. And some of you would look at it and say, well, we do that all the time. That may be the case, but I'm going to tell you there's plenty of times when this doesn't happen. I've seen it from a standpoint of sometimes the more important the person thinks they are, sometimes this occurs more frequently. So anyway, so it's important that you introduce yourself. You would think that would be pretty straightforward. One of the things about establishing rapport, remember that several people when they go to a healthcare provider, sometimes they're intimidated. Sometimes they are nervous. I mean, many times they're nervous because they're afraid of what the doctor's going to say. But it's always good to introduce yourself, make eye contact from a standpoint so that you look like you are engaged. One of the big things that we jump on some of our students on, that clinician-wise, is you guys may have seen them. Somebody walks in, they have the chart, their head's buried in their chart, and that's when they introduce themselves. They're looking straight down in the chart. They're never making contact, really hardly acknowledging the patients. One thing is when my daughter was really ill, we had a surgeon come in with his entourage, his first time he was seeing her. And he walked in and basically just walked right past me and my wife, didn't say a word, walked in and just started talking about when he could schedule the surgery. That was I'm Dr. So-and-so and we can schedule the surgery, such and such and such and such. And as a friend of mine who's a burn surgeon said, he said, when you're dealing with a surgeon, you want somebody that thinks he's God and you don't care. You're not going on a cruise with him. So, one of the things, if you're trying to develop a rapport with the patients, you need to introduce yourself and make them feel like that you're interested in their problem. They need to know that. The environment should provide a sense of privacy. Some of you work in conditions with regard to where that, we had down at the Augusta Hospital several years ago, where the AIDS clinic was, we had individuals that were, telling people, having to break the news to them that they had AIDS, and that was being done in the hallway. So one of the things, especially when you're talking about some of the sensitive things that you guys, especially with mental illness, people that are depressed, trying to get sensitive information out of people and they don't feel like there's a sense of privacy can be a real concern. Minimal distractions. Some of your environments, that's going to be very difficult. But again, you don't want the patient distracted so they're not paying attention and telling you, and you don't want to be distracted so you may miss. One of the things that you may pick up on is that that patient's mannerisms, how they're doing their eyes, how they're, whether they're looking at you, looking away or stuff, could reveal a lot of information. Plus, just picking up on other symptoms that they may not be aware of. That we'll talk about some of these things that may be subtle things, which if someone is watching them, the patient has learned to sort of hide, or you may see that a patient's, the way they walk, just the fact, for example, very straightforward one. If one side of the patient's clothing is unkempt, it looks like it's not buttoned or whatever, one of the concerns was, has this person had a stroke or is there some neurological deficit that's there? Now, this one is controversial a little bit. A lot of places recommend that you sit next to the patient to remove any barriers between you and the patient. Sometimes that, I know some of you that work in the prisons, that's not going to be possible. Another thing about it is some of the patients that you may be dealing with may be extremely uncomfortable. This is one that you just sort of have to play by ear. What you want to do is feel like that the patient, you can interact with the patient. If the patient feels like you're standoff or you don't want to be around them, that they may be, may be very difficult. Sometimes a patient may feel with that barrier between them sitting behind your desk and counseling them. That may be something acceptable. So you have to play that one by ear. So I like the way that you've got the therapeutic modules for the prisons, also known as a cage. I like that. One of the things is that, especially if a patient is feeling intimidated, when you are sitting above the patient, that can create some problems. Or if you, but so you want to sort of let the patient know you're on the same level. Now, again, some of you in the certain circumstances that may not be something you want to do. But the biggest thing is, I think the key point really comes down to this last little phrase here, and that is this: is that letting the patient know. Well, letting the patient know that you are focused on them. Okay. Multitasking, having someone coming in interrupt you a lot. A lot of patients will feel that is not that you're not really interested, or that you could care less. I guess those are one and the same. They are less likely to give you the information that you really need to treat these patients. So that's a key point that we need to keep in mind here. Let me check something real quick. All right, we're going to cover the next 2 or 3 slides, and that'll be a good place for us to stop. So one of the things is put yourself when you're a patient. What are the things that influence you as to whether you want to interact with a clinician? Okay. If some of you are like me, I think we're trained is sometimes we have to go to one clinician because we pretty much know what we need, and we're pretty sure. Like, for example, if I have a sore throat and I know that I've got just a infection, I pretty much know which antibiotic I need. And in one sense, my sense of self-worth and my sense of how much I know is like, why am I taking up, my doctor? I mean, fortunately, I have a couple of doctors that I can call, and I can either run in real quick or even sometimes shoot a photo. But for example, if I've had a sinus infection, I know what a sinus infection is, and I know that I just need an antibiotic. I don't need to go in to see the doctor. I don't need to sit in the waiting room. But the point becomes is that as a patient, I want you interested in me. I want you to be upfront with me with regard to what's going on. I want you to ask the questions, but I don't want you to sit there and go through all of these other questions which are totally irrelevant. Now, if they're potentially relevant, and I may not know they're relevant, then that's something different. I mean, the docs that I've got will say, I know this may sound weird, but I need to know this, and sort of give me a reason. And we're going, okay, I'm cool with that. So, but your speech pattern, think about the intonations that you have from a standpoint of how it's perceived. Sometimes you need to come in and be sort of stern and very firm. Sometimes you need to have some degree of empathy in your voice. Also, your posture. Think about this: if you walk in to see your patient and you flop down on the chair and slide back down where you're slumped in the chair, or something like that, or even if put your feet up on the desk. Some patients that may be fine, but majority of them it's not going to be the case. Your body language. Is your body language receptive? These are all things that can influence the patient's perceptions of you. And this paying attention to small details can make a real big difference in getting a patient to, think about many of the conditions that you are treating. Some of those patients are very vulnerable. Some of those patients are very private, and some of those patients are dealing with, we still have this stigma of mental ease. A lot of people today say, you're depressed, get treatment for it. That's fine. We still have people that being depressed is a sign of weakness. It is an issue that, and especially with things like, addictions, these can be big issues. Some people will wear addiction on their sleeve like it's a badge of honor. Other people would look at, an addiction as just a moral failure. So that's all issue is there. But Joy, you put a point there is that when you feel like they're blatantly ignoring your information, one of the things that clinicians can do is they pigeonhole patients into their practice, force fit them. Okay, so what happens is somebody comes in, and we find that they don't really. They've got a few symptoms that are sort of ambiguous that could be different, and they just treat them like all the patients I'm seeing today have we see this in pediatricians' office, that when one comes in with strep, we see a lot of them coming in with strep. But you do have the kid that comes in that is a little bit different and may have some strange strain that doesn't respond to strep. But one of the things when you're trying to give them what you think is pertinent information, which they may not know is pertinent at this particular point. So one of the things that we want to do is we want to pay attention to the small details, especially because you are getting into a part of their health, which a lot of people either don't understand. Sometimes the patient doesn't understand, but they find it scary. They find it something that is very private. And so these small details can be extremely important. So a couple of clinicians that I've seen, the point has been the way they've acted and come in, it's like you find out that the way they handle themselves, you know they're invested in you and they're going to go want the best for you. All right, let's see. So let me cover these two slides here, and we'll stop here because I want you to think about these initial questions. And in fact, what I want you to think about is tonight, I want you to think is what are some other initial questions that you find in your practice actually are very helpful. So what you want is, first of all, you want the patient to give you their answer or their problem in their own words. Excuse me. Excuse me. You guys know about using open-ended questions and then try to encourage the patient to be as descriptive as possible. Things like, what brings you in the clinic today, or why are you here? What can I do for you? What seems to be the problem today? How can I help you? Those are pretty, those are types to be engaging questions, showing interest, and you're putting yourself in a position where you're asking the patient, tell me what I can do for you. That's an important thing there. But again, be careful about sometimes when you have other caregivers. One of you mentioned sometimes what happens is that it comes in and basically they're giving an account. So sometimes that information is important, but you have to sort it out. Sometimes what happens is with somebody else in the room is basically, what's happening is the patient may have a different perspective, but it's their person. Years ago when the parents got old and, we're getting where you could hardly manage them, a lot of the patients, when you ask them what's wrong with them, it's, well, they're wandering off. They seem to be distracted, blah, blah, blah. Those people wanted Thorazine so that mom or dad sat in the corner and didn't get off anywhere. But when the mom or dad was somewhat cognizant or has some degree cognizant, they might talk to you about, what their thought processes are, their concerns, but the other person, it's a concern there. Jason, you make a good point is you said you can't stand physicians whose self-esteem can't handle a patient who asks questions about their decisions. What I usually I've told 2 or 3 people and physicians have come back not very happy with it, but I've simply told some of my friends when they say, well, I have a good doctor and but he seems too busy, or, he doesn't listen to me or something along the line. And I just simply say, I don't care how good a doctor is. If he doesn't have time for you, if he doesn't care about the questions that you have, then you don't have a good doctor. And I tell them they need to find somebody else. And I feel that way. I mean, basically, there are some times when a patient and a doctor just don't mesh. Okay, it's not that either one of them is bad. It's just they just clash. And even in that case, you probably need to find someone else. But you should feel comfortable. Your patient should feel comfortable asking you questions. Now, you're going to get questions from patients, which they're going to go talk to their friends, and their friends are going to say, well, you got the same thing I had, and my doctor used this, and it works great. So you are going to have patients that are come in and want a specific therapy, specific antidepressant. Maybe that's what was advertised on TV. It's the new hot drug. And sometimes if you don't give it to them, they feel like they're getting secondhand therapy, and they sometimes will make up symptoms and things like that. But, there's nothing wrong with saying, well, the reason I don't give it to you, the reason we're using this medicine is because your symptoms are a little bit different. Your condition's a little different, and you give them that explanation. One of the easiest things we deal with now is it's not on your insurance formulary. You will get sometimes more sophisticated patients that may bring in clinical trials and things like that to show you. I've had patients that have come in, that have come into a clinic that we've been working. It's not my patients, but they've come in and have read something about a clinical trial and they want to know why they can't get it. The doctors looked at me and said, what do you know about this? And I'm going, the key point is it's in clinical trials, which means it's not out and approved yet. So just because it's in clinical trials doesn't mean it's available. And then just to finish up on this slide, a couple of things that we have is, under the initial questions, be aware that the patient may present with an initial dominant problem, but there may be that could also identify other issues. You do have patients that come in with a more pressing problem, but the real issue that they want to talk to you about is the other thing, which they don't want to come in there. So you've got to be careful about making sure that you sort of take all of these and put them into perspective, because you need to explore some of those problems, but maybe independently. So it may be part of something you're going to check out. We don't have a single best way to interview a patient because patient's different. Each one's an individual. So one of the things, because several of you come from different backgrounds than others, is what I want you to think about tonight. Here's your homework, and this will be the last thing we're going to cover. Is your homework is what other initial questions are important or that you find is important, and it may be specific for the area that you're in. It may be that something it's a broad range. So sort of write those down and let's talk about them to begin with tomorrow. So that's one. And then the other thing, which is there's the two videos, which Aiden, I think you've already got posted, if I'm not mistaken, that's dealing with medical chart review, and it deals with some common errors and things like that. So take a look at those two videos. That'll take you about 22 minutes, I think. And we'll stop here so you can do the videos. I'm pretty happy with Zoom. There's a little things I've got to get used to, but I think it's working pretty well. So let's keep our fingers crossed. It seems to have been a better experience than what we've had with Collaborate. And Aiden, I figured you already had it done. So you're always ahead of it. Anybody have any questions? All right, guys, I will see you in the morning at 9 o'clock. And I hope you have a good night. And we'll pick up on this tomorrow. Aiden, thanks a lot for your help. You've been wonderful, and appreciate it. So again, you guys have a great night, and I'm going to sign off here.